Hello and welcome to episode 27 of The Two View, the cutting-edge, interactive, and informative podcast for EM nurse practitioners and PAs. I'm Martha Roberts, and I'm a practicing EDNP and assistant professor in Northern California. I'm here today with my co-host, fact checker, tear jerker, tear wiper, homeboy, and guiding light, Michael Sharma, PA.
You know, tearjerker implies that I cause people to cry. Beyond my 4-year-old, that's actually quite rare. Thanks, homegirl. I am Michael Sharma. I'm a practicing emergency medicine and urgent care PA and adjunct professor of PA studies.
So, Mike, I added this in last minute, and I just kind of wanted to talk about it for a second. It's a letter I received from my insurance company.
Oh,
now,
well, I want to hear about this. I've been fighting insurance for the past few months for stuff on my end as well. It's kind of bonkers how hard it is for people with medical educations to get insurance companies to do stuff. So, typical insuring stuff like they're supposed to. I have no idea how lay people seem to manage it.
I know. It's been pretty frustrating. And you've heard me mention these types of letters before. You could hear them on our previous podcasts. But this one hits home as to why our emergency departments are absolutely flooded with patients. And, I thought I understood it before, but now I really, truly understand it. And I've gone through these things myself, being the patient and understanding how difficult it can be. But I did my due diligence, and I am still having a really hard time as an outpatient. So I went to my PCP about 9 months ago with some arm pain, which I knew was lateral epicondylitis. She sent me to the orthopedic. That took a little bit of time. I needed to get some x-rays, and then I saw the orthopedic. He wanted me to do the armband, which I had already tried and failed. NSAIDs, the other things that we do for lateral epicondylitis. But in the end,
Sure.
I really needed this steroid injection. And he said that, we have to make sure that the insurance approves it. Now, certainly you can pay out of pocket for these things, but they're expensive. So just for purposes, I wanted to let you know of costs. Kenalog or a small bottle of reconstitutable steroid that you want to give to anybody, that you mix with a little lidocaine, it can be anywhere from $40 to $4,000. It really depends depends on the manufacturer, how much, and what it's actually being used for. Now, that's a whole nother show in itself, but back to the letter. I thought, maybe I'll just pay out of pocket, but the letter is asking for my physician to send the following things before I'm approved. It says, Dear Dr. H, we're reviewing these medical records to complete the prepayment review for the claim submitted for Martha Roberts. The information from the review will help us determine eligible expenses under the patient's healthcare plan and help ensure that the claim processing is accurate. But it's 7 pages, Mike. They want 7 pages of information about why they need to give me a steroid injection for my diagnosed lateral epicondylitis.
Wow.
It's frustrating because I felt like the doctor's workup, treatment, and diagnosis was the justification, right? That is the justification. But they want lots of things, all the records, I won't get into the whole list, but it was infuriating. And I felt really sad too, because I have lateral epicondylitis and my arm hurts and all I want is a shot.
I did warn you that maybe competitive arm wrestling was not the sport for you, but you went ahead and went into it anyways, so you kind of get what you get,
Gonna have to go on hiatus.
Yeah, exactly. They're really going to miss you out on tour this year. It's a real shame.
Yeah. So the next time someone shows up to the emergency department asking for, quote, that shot they give for tennis elbow, you can feel their pain.
Yeah, seriously. Gosh. Yeah. I wish I could say that there was some sort of system of that would self-regulate here. I'm not confident that the existing system can or even wants to self-regulate unless they think that self-regulation will net them more insurance company profits. Well, we can't fix that necessarily, but here's something we can fix. Pediatric emergency medicine. If you've ever wanted to go big on little people, there's something new for you, an all-new course that's all about the shorties, September 12th through 14th at the iconic Caesars Palace in Las Vegas. The course is called Mastering Pediatric Emergencies. You know that it's this time of year right now as you're listening to start blocking off your September schedule, and this will be the first and last time this year 2023, that pediatric emergency medicine course goes down. So you're not going to want to miss this opportunity. We have a fantastic faculty of instructors who are acclaimed throughout the world of clinical pediatric emergency medicine and medical education, led by Emily Rose, MD. These are totally new lectures. You've never heard this material before. It's going to be a real treat. Again, that's September 12th through 14th in Las Vegas. We'd love to see you there. Martha, you're going to be there. Is that right?
That's right. I'm hosting the event, and I'm going to be your MC. We're going to have a really great time. It's going to be a ton of fun. And as Mike mentioned, these are never before heard lectures all in one place. So this is a brand new designed, fully evidence-based practice, current guideline assembly of specialists. And Emily Rose is amazing. Al Sacchetti's going to be there as well. We've got some really great faculty.
All right. Yeah, I was looking through some of the topics, and I was really interested in checking this thing out. Well, it's time for our first segment, The Wet Read, where Martha and I get 60 quick seconds to talk about something that caught our eye. The CDC is investigating an uptick in pediatric brain abscesses that started late last year. Much like the invasive group A strep infections that rose up and we reported on episode 23, there was a large peak in incidence of brain abscesses, which is still a relatively rare infection during winter of 2022-23. The textbook triad of brain abscess is headache, altered mental status, and focal neurological changes, but this doesn't even occur in 50% of patients. However, in most patients with brain abscesses, here's what to look for. There is some sort of an ENT infection that presents to your practice late. So it's been already going on for a while, or maybe it was initially treated with something and resisted treated, didn't get better, or some immunosuppression. So look out for those things in your patients. I've been involved in the care of some young patients with intracranial badness of different varieties, and thankfully the patients kind of made it easy on me with some report of unusual behavior, seizure-like behavior, gait issues, lethargy. I've been rewarded multiple times for rejecting the instinct to say, this kid looks fine while they're laying in bed. Because, most kids look okay when they're laying in bed. When I examined or worked up the unusual behavior further, it was rewarding to me and most importantly for the patient. So resist that urge. If you hear about something funny going on, ask one more question, do one more physical exam test, and see where that takes you.
Yeah, that's actually really great insight. I got a medical legal case from Medical Malpractice Insights, MMI, which is an absolutely fantastic email that everyone should subscribe to, of a young male with a brain abscess. And the website is called Medical Malpractice Insights. So you probably can guess what kind of outcome this poor man had. I think it highlights a lot of great points when it comes to parts of the history and lab results that should catch your attention, and some things to consider when it comes to what you should be examining when you hear about potential brain-related symptoms.
Cool.
Yeah. So I want to move on, Mike. And always a hot topic in the ER. We have spoken about this before, the yes-nos, what to do or not to do in the ER. This is often that quick yes-no segment that we do at our courses. And when we are running out of time, Diane will say, is this a yes or a no? And of course, Ken Milne will always be like, well, but, and go into a big, long diatribe, as much as we love him. But I would like, to give us a quick yes, no, or should we not do some of these things. I wanted to bring this alive in our podcast this month in the spirit of going to be at boot camp in July.
Yes.
So oftentimes, patients come in with requests to have medications refilled or ask for a single dose. Now, we've covered this before, but I want to get into some specific medications for yes, no. And I'm going to vote an overall yes for medication refills.
Okay.
Overall, yes, no, but yes, okay, today. So no, not every day kind of thing. So simple stuff, things patients have taken for years, months, whatever. To me, it really doesn't matter unless it's something that is really strange or hasn't been filled in a while. I don't question it too much. I will even give a dose of methadone, opioids, or benzos. It's a 24 to 48 hour yes to me at least.
Okay.
So these are typically the rules for methadone, okay? If you miss your window dose, i.e. you should have showed up, but you didn't, you should give these patients their usual confirmed dose if possible. Otherwise, studies have supported that if they don't get it, they're going to behave in even riskier behaviors like using on the street, heroin, snorting, something else. So don't underestimate the power of addiction and program management. So give them their dose so that they don't divert or misuse or even overdose and die. And that definitely happens.
Yeah.
Some in-house pharmacies, though, do have a cap for these drug dosing, so especially methadone. For example, my hospital will give you 40 milligrams of methadone on off hours between 5 p.m. and 6 a.m. They will allow you to give that dose and only that dose regardless, or lower. Let's say they're on 20 milligrams of methadone, which is rare, but you'll have to confirm it. And It's very difficult to confirm the dose, although you can use your local opioid search engine for the prescription drug monitoring. Just look up the patient, their date of birth, the dose, and if you forgot your username and password, it can be reset in about 5 minutes, or you can ask an attending physician to help you out and use their account together, and you guys can discuss what you want to do. You can also confirm the dosing by accessing the patient's chart, an Epic record, for example, in the EMR. A lot of these are tied to our hospitals. So remember, even if people on methadone, everybody screws up. They're trying to fix their life. So I don't know, give them a break a little bit, Mike.
Okay.
Yep. As far as benzos go, I would say sure. 5 tablets of Ativan or Valium, no big deal. 90 tabs with a 3-card refill, I don't think so. Right. Things that you absolutely should refill yeses to me are antihypertensive, SSRIs, metformin, thyroid medication, even ointments for chronic rashes like psoriasis or fungal infections. And hey, if it helps, throw in a work note to allow them to get whatever it is that they have to get taken care of so that their life can get back on track. Very, very powerful ability that we hold as ER clinicians. And remember, you'd want the same for your friend, your family member, or gosh darn it, for yourself. So big fan on yes, 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 yes. Eye drops for glaucoma to prevent high pressures, even ADHD medications when they're not on shortage for kids who have been on them for years. So be aware that weird stuff, like I told you, patients that just got started on HIV meds, antibiotics, names of drugs you've never heard of, things from Mexico or other countries that have just come over. Levels may be needed for seizure medications. So use your due diligence and your brain. And I think that will behoove everybody.
Okay, so it sounds like your answer is yes, but ... I have to say my answer is no, but ... In general, my personal guideline is when there is a higher risk of the patient suffering an organic medical issue by me not prescribing the medication, then I should consider prescribing the medication. That's my general guideline. And it goes beyond whether me prescribing it is going to vaguely help them or not. In the end, if I'm giving them a benzo, I'm going to give something long-acting like chlordiazepoxide or Librium with the goal of preventing withdrawal and not necessarily matching the effect of their usual benzo. I will defer to you on the methadone thing. I have no doubt you see a lot of those patients at San Fran. I do also share concerns, like you mentioned. I don't want someone to fall back into their bad habits, right? If this is keeping them from abusing, then I don't want them to fall back into that. I totally agree about being wary about a lot of these specialist-initiated medications of weirder stuff, to include what we just talked about, right? The intra-articular steroid injection. Steroid injections into joints are not totally benign. There is some variety from orthopedists about how often someone should get steroids into a joint. There are 0 emergencies in which inject steroids into the joint are the immediate life or limb-saving intervention indicated. So you hard pass on that for me in the ER. I have a pretty short list, frankly, of medications I feel are appropriate for us to refill. I'm totally okay with high blood pressure, diabetes, high cholesterol, glaucoma management refills if they've been on them recently. There's probably more, but in the end, the potential for organic medical emergency with me not refilling is my guiding principle. There is one tactic I will use in the not unusual situation of quote, I need a refill of this medication, but I don't know X, where X is the dosing instructions, the strength of the medication. Heck, sometimes even the name of the medication itself. The patient's like, it starts with, rhymes with. It's a little pill. It's like, yes, they're all little pills generally. I'll write on the prescription or in the discharge instructions and, of course, tell the patient that the patient and the pharmacy have to verify the previous dose or medication or unknown information somehow. The patient needs to bring in the bottle, or they got to contact an old pharmacy, something to verify the prescription. And if the old prescription doesn't jive with the new prescription, have the pharmacy call us back, and we can fix it and make sure they get on the right thing. So there's ways for these people to communicate back to us after they've been discharged.
Yep. Mm-hmm. All right, so we're going to move on to segment 2. This is our dry scan where we penetrate a little deeper into 2 other topics. Mike, I want you to start with yours.
Nuts. It's time to talk testicles, specifically testicular torsion. This problem falls into one of my favorite broad categories of emergency medicine problems. Problems where time is of the essence and a strong clinical call based on history and physical can save the day. The textbook presentation of testicular torsion is an acute, severe testicular pain, often accompanied by vomiting, with an ultrasound suggesting a lack of blood flow to that testicle. Unfortunately, testicles don't read textbooks. A single-center retrospective chart review of about 200 pediatric torsion cases between 2011 and 2020 in Lithuania was published at the end of 2022, and it identified some trends that significantly increased the odds ratio of someone eventually being diagnosed with a torsion. From highest to lowest, the authors noted that age greater than 13 years, onset of pain less than 5 hours, a hard testis on exam, vomiting, scrotal edema, and abdominal pain as factors that increase the likelihood of a patient having torsion, with the first factor I mentioned, age greater than 13 years, having an odds ratio of 8.4. Wow. Also of note, 41.7% of patients eventually diagnosed with torsion in this study had blood flow observed. Patent blood flow through to the testicle in question. Ultimately, you cannot hang your hat on diagnostics here. As you know, viability of the testicle is thought to drop significantly after 6 hours of torsion. So, what do you do when a patient with torsion shows up after gutting it out for 5 hours? We've heard of the open the book procedure where you use your hands and externally rotate the testicles, as it's thought that most testicles twist inward with the goal of restoring some blood flow. It's a little more complicated than that, though. It's thought that up to 1/3 of testicles twist outward. The edema and severe pain involved can also make things uncertain when you're down there and trying to decide which way to go. A letter to the journal Pediatric Emergency Care suggests a tweak to the technique. The authors offer a few case reports that suggest that applying inferior traction, stretching the spermatic cord to its maximum length, can sometimes cause the testicles to naturally untwist in the direction that releases tension, and then you can manually continue that untwisting. This isn't validated or anything, but mechanically it makes sense, and it's unlikely to cause any additional harm in a situation where time equals tissue. Obviously, some strong analgesia before employing this traction technique would be helpful for all involved. In case, I'm sure Shorzy would be proud if you give this a try.
Shorzy. So,
do you know Shorzy? Do you know what I'm talking about?
I do, and actually, that's one of my partner's favorite shows, too. So, it'll be, what does he say? I can't do it. Good.
Well, I don't think we want to do it on the podcast.
No, never mind. Forget it. Okay. So,
that was for Jason.
Yes. Yep. So there's a note here that states I need to talk torsion. All right. So by torsion, yes. Okay. You've already talked torsion. I want to talk about CT, ultrasound, and ovarian torsion. Okay. And this may be super old news to many of you, but there have been some back and forth studies since the 2013 study in the European Journal of Radiology. And we all know undifferentiated abdominal pain in females can be tricky, even for the well-practiced clinician on site. I'm talking about the head-to-head study on CT versus ultrasound in the ER to diagnose ovarian torsion in females with lower abdominal pain and pelvic pain. The bottom line is that the negative predictive value of a normal CT is about 99% regarding ovarian torsion. If you have a positive CT scan, abdomen pelvis CT scan, with radiological findings of torsion, you can forego the transvaginal ultrasound. In fact, in this paper, the abdomen pelvis CT demonstrated a sensitivity of 90 to 100% and specificity of 85 to 90%. Importantly, a CT demonstrating normal ovaries effectively excluded ovarian torsion.
Huh.
So the conclusion here, the diagnostic performance of CT, it's not much different from that of ultrasound, but basically here what they're trying to say is that if you went ahead and got the CT done, you don't need to go ahead and get an ultrasound to confirm your diagnosis, which, by the way, some people, I hate to say, I've seen them do. So if you're...
I totally do this. Yeah, like I totally will say like, oh, I'm so concerned, I'm going to get an ultrasound. But this is seriously news to me.
Oh, okay. Well, actually, that was a really good paper that I had referenced. It'll be in our liner notes. If you're more concerned about ovarian torsion and you decide to opt for the CT, a follow-up ultrasound is not necessary, Mike, to rule out this torsion, just so you know. And then the CT will also show you a lot more, as we know, than the ultrasound. If your physical exam workup and history is not 100% exclusive for the diagnosis of torsion, hence our undifferentiated abdominal pain workup and plan. Now, a lot of people lose their minds trying to figure out, I see new graduates do this a lot. Oh my God, they have lower belly pain. I have to do 1,000 things. It's not true. I mean, there are definitely signs and symptoms that are classic of certain diseases and illnesses, but there really truly are patients with undifferentiated abdominal pain that are telling you things subjectively that you're like, wow, that doesn't make any sense with what I'm finding. Okay. And then you have to think to yourself, well, the patient is telling me that they have excruciating pain in the right lower quadrant, but they're also vaginally bleeding. And I could go on with, multiple complaints that patients have that make us sort of think, well, could be appendicitis, or is this just a really, bad period, or is this ectopic, or, I could go on. Anyway, there of course are pros and cons of using unnecessary radiation on a patient. I'm not saying that we should just jump to the CT if we're thinking that there's torsion. Of course, ultrasound can still tell us if there's torsion, but I'm going to get to that in a second. Basically, if you're ruling out other nefarious lower pelvic pain issues in a female, which don't just include torsion, moving to a CT may be necessary, but we might consider the exam and history a lot more, and then be very cautious about adding the CT in young females, maybe even getting the attending physician involved. Sometimes that can be helpful. The best bet is to know your hospital protocols and your consultants. So it's very rare that when I feel confused about something that I can't call a specialist, right? Mm-hmm. Like they love to say, well, tell me the history. Let's talk about the tests you want to do. In a particular case, if torsion is your only and main concern, given the exam and history, transvaginal ultrasound with grayscale imaging and Doppler flow is usually the diagnostic modality of choice for detecting torsion. But it has high specificity and poor sensitivity. So ultrasound revealing torsion will have the color Doppler show decreased or absent intraovarian venous flow as the ovary is torsing. And then the late stage showing no arterial flow as this progresses to be worse. The issue is that the reliance on this normal arterial flow to exclude torsion, the ovaries have dual blood flow and arterial inflow is not really compromised until late courses of the issue. In fact, according to a recent publication, cited with numerous references in the 2020 ACEP Now, arterial flow is completely normal in more than 25% of patients with surgery-confirmed torsion. Also note intermittent or partial torsion may also result in normal venous flow on the ultrasound. So this is a little rough game that we have, right? The authors of this publication state that they do not rely on normal vascular flow to rule out ovarian torsion. A combination of the transvaginal ultrasound findings such as ovarian enlargement and mass, free fluid in the pelvis, and vascular flow may improve your ability to diagnose ovarian torsion. And Mike, lastly here, what's also interesting from the authors from this ASAP Now publication is they conclude that if the ovary is abnormal on the CT, then getting the vaginal ultrasound isn't necessary to go on to confirm your diagnosis, but go ahead and consult the OBGYN. It's a time-sensitive condition, and they're going to help you figure out what the next step is if another test is indicated, which most times it's not. You can also check out ASAP or ACOG guidelines, which we'll put in our liner notes.
Yeah, and these liner notes are, as always, at 2view.fireside.fm. That's the number 2view.fireside.fm. You'll put that in, and you can do, backslash or front slash, whichever, one of the slashes, right? And then 27 is this episode. So 2view.fireside.fm. Well, it's time for our last segment, which we call Oral Contrast, where we get into all the nooks and crannies of a topic. And Martha, you picked this one. I think it's a great topic.
Yes, the acute psychiatric patient in the ER. Let's get right to the guidelines and then chat a little bit more about them. They can be found on ASAP's website.
And we'll have that link in the show notes as well, of course.
So, Mike, number 1. In the alert adult patient presenting to the emergency department with acute psychiatric symptoms, should routine laboratory tests be done or completed and used to identify contributory medical conditions, non-psychiatric disorders?
Okay, so the policy suggests that do not routinely order lab testing on patients with acute psychiatric syndromes. Use medical history, previous psychiatric diagnoses, and physical examination to guide testing. And I love this. Like the knee-jerk reaction on a lot of hospitals is like, hey, this person has some psych issues. Maybe they're getting admitted. We better clear them for admission, right? Which that usually means knee-jerk ordering a bunch of lab tests. But as we know, it's not about what we're not treating the lab tests, we're treating the patient in front of us. So I love that ASAP backs up emergency clinicians in this way.
Yes. Very good. Number 2, in the adult patient with new onset psychosis without focal neurological deficit, should brain imaging be obtained acutely?
Okay. Their response is use individual assessment of risk factors to guide brain imaging in the emergency department for patients with new onset psychosis without focal neurological deficit. I guess their idea is that if there is something wrong with the brain, they won't just be having new onset psychosis, there should be some sort of deficit. You've probably had a mix of these where you've caught a person who everyone thought was acting spacey and they actually had some sort of intracranial lesion going on.
I just had one.
Oh, gosh. Okay, that's terrifying.
I literally just had one.
We'll talk about that one offline. Okay, what's next?
Number 3, in the adult patient presenting to the emergency department with suicidal ideation, can risk assessment tools in the emergency department identify those who are safe for discharge?
This is interesting. In patients presenting to the ED with suicidal ideation, physicians should not use currently available risk assessment tools in isolation to identify low-risk patients who are safe for discharge. The best approach to determine risk is an appropriate psychiatric assessment and good clinical judgment, taking patient, family, and community factors into account. The more the merrier, I guess. And just like we're not going to be treating the lab results necessarily, we shouldn't be treating these risk assessment tools. These tools should be used to guide us, but they should not be the end-all, be-all in determining who's high and low risk.
Yeah. All right, and then lastly, number 4, which we're going to talk about a little bit more here to end the podcast. In the adult patient presenting to the emergency department with acute agitation, can ketamine be used safely and effectively?
Special K. Ketamine is one option. That's what they say. One option for immediate sedation of the severely agitated patient who may be violent or aggressive. I know you want to spend some time discussing this ketamine in detail for the treatment of acute psychosis, or, it depends on who you ask, right? So hyperactive delirium, some folks call it excited delirium, and we'll explain kind of where this terminology has been kind of changed or adapted here shortly.
Yeah, so quick yes, no, Mike. Number one in the alert adult patient coming into the ER for psychiatric complaints, do we get labs? No. Number two, if the patient has a new onset psychosis without a focal neurological deficit, should we get brain imaging? Nah. And in the adult patient with the SI complaint, should we risk assessment tool them only? No. It's a multitude of factors here that we use.
Right.
And then lastly, can you give ketamine? Sure.
Most definitely.
Yes.
Yeah.
But my short answer to treating the acute psych patient, either violent or possibly is getting violent, is to have a good go-to medication. And I often think about so I like to just have my medication. I like to have my medication. I want to hold it. I want to cuddle it. I want to know that it's there for me. And then the only thing that I want to think about is when not to use that. Any other time, it's like, take this, take this, take this. But when is it not okay to use it? What I mean here is that I use Ativan frequently for acute stress reactions, panic attacks, even sometimes a motor vehicle crash in a patient where there's an acute mental trauma, no physical findings. Ativan is my go-to for lower acuity psych patients, 1 to 2 milligrams, especially the crying patient, who maybe did a few too many hits of weed in the park, that kind of thing. Depending on weight intolerance, I don't use Ativan for patients who have a very high tolerance or who are on high doses of clonazepam or Valium. And I also don't use Ativan when the patient is in severe psychiatric crisis. Okay? Yeah. That's when I bring the big guns like ketamine.
Right. I love that thought process of have your go-to that you know what you're going to do. The time to think about that go-to is before you're confronted by the highly agitated patient that may even pose a danger to themselves or also fellow patients or staff. You don't want to be thinking about that during the confrontation. The ASAP guideline itself states, quote, ketamine is one option, close quotes, for immediate sedation for a severely agitated patient who may be violent or aggressive. We also know that ketamine has been used for depression, acute depressive states, for patients that present to the ER, even patients with suicidal thoughts. A low number of ER clinicians are going right to the diagnosis of acute depression and starting ketamine in that ER visit. We understand that that's happening. What we want to highlight is that it doesn't matter what we're treating in the end. Regardless of what we're treating, we have to consider drug-drug interactions before we jump right to the K button every single time. Psych patients may already be taking other medications or tend to begin with that can interact with the ketamine. Yeah,
so we have a lot of clinicians that are very astute and using ketamine, like you said, right away. They're jumping right into it for depressive and SI states. Like, okay, fine. Maybe you're not 100% comfortable with that. And the literature is interesting. I mean, there's a lot of literature out there. But the big drawback to ketamine are drug-drug interactions. And our pharmacology department and our pharm people at the General, we talk about this frequently. And after looking at a 2021 meta-analysis, looking at 24 studies in the International Journal of Neuropsychopharmacology, I mean, could we be a better journal for this topic? They concluded the following in regards to drug-drug interactions with ketamine. For lithium, no significant interactions with ketamine were reported. 2 out of the 5 studies for lamictal indicated that the effects of ketamine were attenuated or reduced. Benzodiazepines are repeatedly shown to reduce the duration of ketamine's antidepressant effect. And for the MAOIs, case reports showed no relevant change in vital signs during concurrent ketamine use.
Okay.
One paper indicated an interaction between ketamine and haloperidol, and 2 studies did not. 4 papers investigated risperidone, including 3 neuroimaging studies showing an attenuating effect of risperidone on ketamine-induced brain perfusion changes. And clozapine significantly blunted ketamine-induced positive symptoms in patients with schizophrenia, but not in healthy participants.
Oh boy.
One paper reported no effect of olanzapine on ketamine's acute help me out.
Yeah, I think it's psychotomimetic effects.
Thank you. So the conclusion from this meta-analysis was that current literature shows that benzodiazepines are probably a problem with ketamine. Lamictal can also reduce ketamine's treatment outcome. These things should be taken into account. These are drug-drug interactions we need to think about. And maybe we don't know if the patient is taking too little, too much, or not at all of these medications before giving ketamine. I think that the studies on ketamine are mixed in psych patients because of all the polypharmacy that patients may or may not, or we can't confirm, are on or are not on when we give ketamine.
No, totally.
It's hard. It's a very difficult drug. I think people are very quick to say ketamine, ketamine, ketamine. But I just am not on board 100% with it.
Yeah, that's a lot to think about as an ER clinician, especially when someone is bearing down on you, looking very upset and agitated. I think, you really want to think about, it's one thing to hear about ketamine and go, oh, I've heard ketamine is a good thing to use in a situation. I think that you're really going to want to think long and hard about whether that is going to be your go-to, or whether you want to consult somebody who is more experienced in giving ketamine. Perhaps it's physicians, perhaps it's mental health NPs, or maybe it's the behavioral health team.
Why not call the toxicologist? I don't know about you, Mike, but maybe just because my father was a toxicologist, and there were very few toxicologists in the country for so long. Now we have a lot of them. But Mike Hyun and Leslie Wolf, they're 2 toxicologists that I have on my speed dial, and they love calls from me any hour of any day. Not, sometimes I just talk about past cases and what they would have done, if you were in this situation. But toxicologists, they love to weigh in. Maybe if you have a fellow, just tell them, be like, hey, I'm thinking about doing this, or I would love to talk to you more about ketamine. Talk to a toxicologist. Make one your friend. That's my message for the episode today. But anyway, back to ketamine. Is it an option for a patient who's ripping TVs off the wall and hitting staff and going crazy? ASAP says sure, it's an option. I just want to say briefly that the now archaic, and should I say extinct term, excited delirium, as Jim rolls over in his box on my desk here, yes, my father's ashes are right here. He was really into excited delirium for many, many years. But now ASAP, they don't recognize that term. What they do recognize is that the existence of hyperactive delirium syndrome is severe agitation, potentially life-threatening. It's a clinical condition characterized by a combination of vital signs that might be abnormal, like temperature, blood pressure, also this really pronounced agitation, altered mental status, and metabolic derangement is a big key here. So these patients are still at high risk for direct physical trauma, harm, all kinds of other problems. ASAP does believe that this needs attention, certainly with all the cases that we've had in the news. And they have a wonderful task force. Gosh, I went down this rabbit hole of task force by ASAP. These papers are fantastic. I mean, read them. These people have put together an incredible group with the goal of treating patients with signs of hyperactive delirium syndrome and what to focus on by reducing stress and preventing physical harm when they present to the emergency department.
My personal quick reference on this topic of what to do when someone comes in there agitated is the work of Ruben Strayer. Ruben Strayer is an emergency physician who works in New York City, trained in Texas, like a lot of the good ones are, and writes at emupdates.com. He has a good kind of map, a flow chart on deciding what to use and when, and we have, again, got a link to that on our website 2view.fireside.fm. That's the number 2view.fireside.fm. His first decision point he uses is whether the patient is moderately agitated or severely agitated. And hyperactive delirium would fall into that severe agitation category. An easier way to think of what category they fall into is this. Is the patient an immediate danger to themselves or others? And things you could consider are whether they could have like a truly emergent medical condition, like a trauma that needs to be addressed, but patient factors are preventing that, and whether they cross the line between just disruptive and truly dangerous, combative, or otherwise just uncontrollable. Depending on the patient's suspected comorbidities and other medications on board, for your moderately agitated patient, he generally recommends midazolam, Versed, or some other or some sort of first generation antipsychotic, either haloperidol or one of our favorites on the podcast, droperidol, or sometimes a combination of both midazolam and one of those antipsychotics I just mentioned. Those first generation antipsychotics are known for being more sedating than the second generation ones, and that's kind of what we're going for here. He specifically recommends a different antipsychotic, olanzapine, when the patient is at high risk for long QT syndrome, like with methadone use, we mentioned that earlier, cardiac medications, or multiple psych meds. But for the patient who is uncontrollably violent or suspected to have an emergent medical condition requiring resuscitation, he does recommend ketamine at the dissociative dose of 4 to 6 milligrams per kilogram intramuscularly. So, this is not the time to try to get an IV when the patient's arm is thrashing around and striking you in the face. You could just remember 5 milligrams per kilogram if that makes it easier. That would mean the average 100 kilogram person gets about 500 milligrams. There you go. So it's kind of easy math. There's a lot of other good clinical pearls on his page about the agitated patient, like how about injecting large volumes and through the clothes should be considered in patients with severe agitation, like I just mentioned, and other things to help patients safely, like removing those physical restraints, Martha, that you talked about by using a oxygen face mask with the oxygen turned on and putting that over the mouth. A lot of folks get concerned about people biting or spitting. These patients sometimes need oxygen, and so high flow oxygen through a mask over the mouth, it helps the patient, and it's safer potentially for the staff as well. He gave a 26-minute talk on the topic on his website. We'll link to that, emupdates.com, the specific page on his website with that talk. I thought it was amazing, very funny, very hard-hitting, and very actionable information. One last thing I think is interesting is this. Nowhere in his recommendations does he mention diphenhydramine or Benadryl. I know the old B52, which stands for Benadryl, 5 of haloperidol, and 2 of lorazepam, is something that people have been doing this for a long time think of when it comes to the agitated patient. We've got a link to the Aliem blog, Academic Life in Emergency Medicine, and it's a 2022 article that questions whether diphenhydramine is still indicated in the agitated patient. They suggest that it may not be necessary and that it may increase ED length of stay without added benefit. I don't know about you, but the last thing I want for an agitated patient is for him to stick around longer in my ED. And maybe time to ditch the B52 and use this memory device instead. If the patient is uncontrollably violent and or needs emergent resuscitation, tire them out by making them run a 5K. That's ketamine, 5 milligrams per kilogram, the dissociative dose. Otherwise, consider consulting 25 MDs. What's wrong with this guy? I got to consult 25 MDs. That's midazolam and droperidol with starting doses of 2 milligrams midazolam and 5 of droperidol, 5 milligrams of droperidol. Think muscle and midazolam M&M. It works quickly and reliably by the intramuscular route. Perfect for someone who is not going to want to sit still for IV access. Consider going higher at 5 or 10 milligrams midazolam in patients with some sort of sympathomimetic toxicity. That's like coke or methamphetamines or ecstasy. Or in patients in withdrawal from sedative hypnotic drugs like benzos, alcohol, or maybe even GHB. Also, if you don't yet have droperidol in your ED, I don't think I do. If you're substituting haloperidol or olanzapine, increase the starting dose of that medication by 50%. Lastly, it's important we get ahead of our patient. Understand that midazolam can cause respiratory depression. Get ready to manage respiratory depression if you're taking a patient down like this. Catch it with oximetry and even capnography if you have it. That's a whole huge topic here, and it's fraught with medical legal implications. It's fraught with, oh my gosh, I just sedated this patient. Now I have to own them or resuscitate them. So I love what you said, Martha, is have a go-to and know when you wouldn't. But otherwise, go to the go-to.
Right. All right. Well, Mike, I got something sweet to end the podcast. You don't, but I have something for you.
I'm sweet enough by myself.
Do you know what I have here in my hand?
Oh, yeah. Hey, Japa. Cool.
Yeah. So I got something for you, and then I'll do mine. So this is actually kind of cool. I don't always read this. It's The Art of Medicine. It's the last page.
Okay.
And it's actually an interesting little piece by...
Who wrote it, by the way? Oh, sorry, you're going to say it. Brian
T. Maurer, Maurer.
Okay, cool.
And he's a PA. And it's an interesting... it's a conversation. And, you know, I think it takes a special person to write a conversation piece between two people. And I think that this person did it in one page very, very well. It's basically documenting the conversation between a surgeon and a pediatric specialist. And I think it's really a testament here to how incredible pediatric providers are over the years, particularly this one who's been practicing for 40 years, because literally they could talk to any specialist and be like, yeah, I remember that patient when they were 2, when they were 5, when they were 10, when they were 18, when they were 25, still coming to me. And it's amazing, like when I was growing up, my father would say, oh, it was a patient sent from Dr. blah, blah, blah. And it was like, oh, everybody knew that one particular pediatric specialist, you know, like, oh, like we're so glad that that's so-and-so's patient because we know that that patient's been getting good care. But the last line in this, and I'll let you all take a look at it. It's the June edition, 2023, volume 36, number 6, last page 50. I really admire you guys who work in pediatrics, he says. You have got to have the skill set to treat a family as well as a child. Not everybody does. And he adds, you've also got to have the patience of, he goes on to talk about basically what it takes to be in 4 decades of pediatric practice. So patience and patience. So anyway, I did your something sweet for you.
Thanks.
My something sweet is, let's talk about Bobby or Bobby. How do you think he says his name? Is it Bobby?
B-O-B-I sounds like Bobby.
Okay. I think it might be Bobby. You know? Is it
Bobby?
Bobby?
Bobby.
It could be Bobby. This is a 31-year-old dog. Sorry. This is a 31-year-old dog that had allegedly been alive since 1992. Bobby was born May 11th, 1992. He's a small, purebred Raffiero de Alentejo dog, cared for Leonel Costa de Conqueros in Leiria, Portugal. Leiria. I don't know what my problem
Leiria.
is. How do I don't...
Of Conqueros, Leiria, Portugal.
Okay.
Let's just say that.
All right.
Yeah.
So on, like I said, on May 11th, 1992, the dog was born. So on May 11th, 2023, Bobby turned 31. And that makes him the oldest dog on record ever to live. So his age of 31 surpasses the previous record held by Bluey, a female Australian cattle dog from Victoria, Australia, who was 29 and 5 months. And that was the oldest dog. Well, what can we learn from Bobby Bubby. And did you know that there's a Wikipedia page dedicated just to him? The owners have stated that he's in reasonably good health for his age, and although he has trouble walking a little bit and he's got bad eyesight overall, he's got good health. He had a little bit of a trouble in 2018, but he got better, and they think that he is the way that he is because of the calm, peaceful environment in which he lives in and the consumption of fresh foods instead of kibble, and also can be contributed to his genetics. His mother lived to be 18. So in honor of his birthday, they had 100 people come. They had a big old party, and they had fish and meat, and they had a performance of dancers. That sounds fun. Anyway, we know that dogs can live long for a variety of reasons. Chihuahuas actually live a really long time. My friend's Chihuahua, Becca Quo, her Chihuahua lived to be 18. I knew that dog. It went to school with us. And a special shout out to Dr. Rick Bucata, who lost his little 11-year-old Benny a few weeks ago. And we know dogs are very special to their owners, but Benny was extremely special to Bucata, and we're very sorry to hear that.
I bet Benny was a good dog, and I'm sure Bobby was as well. We have, again, we have pictures. We have a link to Bobby running around in his native Portugal. I found Dr. Maurer's article, When the Past Becomes Present, from JAPA, June 2023. So I'll have links for those things on our website, 2view.fireside.fm. That's number 2view.fireside.fm.
So last month, we asked what famous American love goddess, actress, dancer, and performer died of Alzheimer's disease in 1987, and what famous movie showcased her as the femme fatale in her first major dramatic role. And the answer was Rita Hayworth, and the movie was Gilda, and the winner was Debbie McBride, a PMP from California, an actress, dancer, wonderful lady, 1940s, top stars, appearing in over 61 films in over 37 years. The love goddess described Hayworth perfectly, and she became one of the most glamorous screen idols of the 1940s, and she was a top pinup girl for the GIs in World War II.
In 1980, Hayworth was diagnosed with Alzheimer's disease, which contributed to her death at age 68. The public disclosure and discussion of her illness drew attention to Alzheimer's, which was largely unknown by most people at the time, and helped to increase public and private funding for Alzheimer's research, and we'll have more information about that on our website as well. Well, let's shift focus to our new question this month, and you're going to want to listen up because, hey, maybe you'll get... dare I say it, a free course? Is that fair to say?
No.
Free course?
No. 20%. 20%.
Okay, all right. Hey, in this economy, folks, what are you going to do, right? So 20% off a course if you answer this question right. Here's the two-part question. The two-part answer will be yours to provide. Ketamine can sedate humans as well as animals. However, there is one animal in which ketamine seems to produce excitatory effects. In which animal does ketamine seem to produce excitatory effects? And in which year was the paper published that detailed these findings?
Email us your two-part answer in addition to anyone you'd like to give a shout-out to, as well as any feedback from any episode or this episode. You can send that to the email address 2viewcast@gmail.com. That's the number 2, viewcast, all one word, @gmail.com. All right, that's it, Mike.
That's it. More information on the original and advanced emergency medicine boot camps, the emergency medicine and acute care course. We still have a couple of those coming up this year in cool locations. I think New York City's coming up. Is that right? NYC? Right? Yep. Or any of our courses are available at the Center for Medical Education website. That's www.ccme.org, www.ccme.org.
All right. Well, new and upcoming courses this year, so many fun things. And we have our boot camp, as we mentioned, coming up in July, the 25th through the 28th. Our procedures and ultrasound and pharma course 2 days before the camp. They're still open, so check our website for more information, ccme.org.
Yeah, spots run out on those pre-camp sessions just because we want to keep the instructor-to-person ratio low and manageable so you get really good learning out of that. So you're not going to want to, miss out on that and sign up in too late and see that you were kind of like if you just signed up a day earlier, you could have made it into that course. Thanks for listening and attending this episode of The Two View. You can subscribe and rate us on Apple iTunes Podcasts, Google Podcasts, and Spotify. Search for 2View Emergency. That's the number 2 View Emergency, and it'll come right up. Ratings help us climb the charts so that other clinicians can get some 2View goodness. If you like YouTube and want to see the video blog instead, you want to see my fetching Hawaiian shirt that I'm wearing for the summer, you want to see that nice guitar in the background of Martha's image here, then search for Center for Medical Education on YouTube, or even just go to like ccmelive.org. That points to that. So ccme.org is our home website. ccmelive.org goes to the YouTube. You can catch the video version of our podcast. Don't forget our website where you can go next level on any of our topics from any of our episodes, including all the papers and sites we refer to, including Bobby. That's 2view.fireside.fm. Our audio and video engineers are Ricky Bucata and Dave Pett. Show notes are by Meg Dipple.
Thanks again for tuning in, friends in EM. Share this podcast with a friend. Share your thoughts via email. And thanks for sharing your time with us at the 2View. Have a good day and a great shift.
Good dog.